the research lab, we focused on synthesizing new HIV like antiretroviral therapies, which was really cool, and that really got me interested in like HIV as a whole in terms of like the public health issue, the stigma surrounding it, sort of the whole history. And so Creighton University Multicultural Health Science Student Association plans HIV and AIDS Awareness Week every year. So if you're in the Omaha area, I highly encourage you to look out for that when it is coming around. But what we do is we try to bring in, you know, HIV positive patients who speak about their experience having to be on medications. We bring in people who are experts on the content, researchers, pharmacists, and all of those good things, just to kind of hear the whole perspective on what the HIV landscape is looking like in Omaha, which I know not all of you are from the Omaha or Nebraska area, so if you're around for that, we would love to have you. In addition, I guess before I jump into the actual presentation, super informal. If you have questions at any time, please feel free to stop me. Just to like get an idea, I guess, of like you guys. I guess show of hands for people from like Nebraska or working in Nebraska. Okay, and then the rest of you from out of state as well. I'm sorry, where? Colorado. Colorado, and you said New York.
Washington.
Washington, the state?
State.
Or, okay, Washington State. So this will probably be a little more directed toward the people here, but Colorado has really cool laws where pharmacists can prescribe like PrEP and all of that things, which is really neat, and hopefully that's something that can be transitioned to other states as well. And then on top of that, I guess, where location, we're hospital, anyone in a hospital setting? Hospital setting, retail, community, pharmacy?
I'm like hospital, but I also follow the patient home.
Oh, okay, very cool. Community retail setting? Long-term care specialty, anyone in that arena? Specialty? Are you at?
I'm here.
Okay, I was gonna say. And then any other like special type of like industry type of people? Okay, so a good mix of everyone around. But I guess basically to top this all off, my whole thing is that, you know, I guess my purpose or wanting to talk about this is just the education aspect of, you know, HIV as like still being a social stigma and a lot of people still having, I guess, preconceived notions about it. And I think the more we talk about it and the more we talk about the available therapies and the prevention of it, it allows us as like very accessible healthcare providers to be able to sort of flip that stigma or like work toward, you know, changing the whole viewpoint on it, which I think is really cool. So these are just a couple pictures from Creighton University's HIV/AIDS Awareness Week pre-COVID, so we could, you know, like feed you guys and like all of that fun stuff. Now, I don't know, this past year was all online. This upcoming year, I don't know, I'm hopeful, but we'll see. And then this is just a picture of my sister and I. She goes to Creighton as well. She's in business school though, so nothing healthcare related, but we both did help with COVID vaccine clinics, which was really cool to get to do that with her. Okay, so kind of just jumping into like the background of HIV as a whole, you know, the 1980s, kind of like when everything came to light. But what I really wanted to focus on here was looking at the data from 2018, which is the most recent CDC update that they released, and looking at the fact that at the end of 2018, 1.2 million Americans had HIV. Okay, that's a lot of people, but the number that really gets me on here is that only 6 out of 7 knew that they had the virus. So what about that 7th person, right? That to me is like, whoa, how can you have such like a disease that could progress to AIDS but not know? And so the big thing that I also want to key us in on is the 56 out of 100, so 56% being virally suppressed. So we know as, you know, pharmacy technicians, we have patients who are better at picking up their medications than others and better at being adherent. And looking at that 56% number, it's concerning because that means that, you know, maybe these people were being treated, maybe they're not in here, what's going on with there? And so I think that these numbers sort of paint a picture of where we're at as a whole in the US. And I think there's just a lot of work to do here. And I think as, you know, pharmacists, pharmacy technicians, you see a lot of patients, you have a lot of direct contact. These are just really great interventions and opportunities where you can talk to patients about adherence or ask them about like, is cost an issue? And I'm going to talk a little bit about resources. And so I just wanted to kind of bring this to the forefront of all of our minds. And so with that, we talk about like public health recommendations. And so within DHHS, or the Department of Health and Human Services, I think it's really interesting that they recommend that everybody should get tested for HIV at least once in their lifetime. And I guess I won't make us raise hands, but like one of the activities that Creighton's HIV/AIDS Awareness Week did was we hosted the Douglas County Health and Department of Health and Human Services to come and do HIV tests. So I, don't have any of these risk factors, but based on these guidelines, I went and I got an HIV test just, to know for myself. And I think that's something really interesting that maybe not a lot of people know about right now, and not a lot of people are attuned or aware to. That being said, if patients do have additional risk factors that are listed on the board, so like sharing IV drug use or IV drug users sharing IV drug paraphernalia, high-risk sexual behaviors, anything like that, then obviously they should be tested more frequently. But I think it is interesting that, the Department of Health and Human Services does recommend that everyone ages 13 to 64 get tested at least once. So if you take nothing away from that, take that away and just think about that and just being the awareness so that, that seventh person can find out that they have HIV and can move forward and figure out what they can do from there. Additional things, most of the time we'll run like an HIV antibody and antigen immunoassay. Most of the time it'll be done in a clinic or hospital setting, nothing we as pharmacy have to technically worry about. But I did want to bring our attention to this OraQuick in-home HIV test. So it is an over-the-counter test. I see some of you nodding your heads and you know about it. What is really important to note about this, if you have a location that sells these tests or you work in an area that sells these tests, is that patients should not be using it to test unless they've been exposed greater than 3 months. So this at-home test only works if you've been exposed greater than 3 months from when you're going to take the test. Not a lot of people recognize that, so you're gonna be like, oh, I got exposed, I'm coming in the next day, I'm gonna take it. And it's like, ooh, great that you're like, thinking about it, but unfortunately it doesn't work that way because your body needs time to build up the antibodies to it. So I'm sure this isn't the highlight of the entire presentation, but we do have to kind of briefly go through the life cycle of how HIV works so you can have a little bit better understanding of how the drugs work in the body, and more importantly, like how the new drug that's on the market is so cool and why it's really neat. So HIV, I've thrown it out there multiple times, and I should take a step back and just reiterate for myself that HIV stands for human immunodeficiency virus. Again, it's the virus that causes the HIV infection, and I think it is really important to differentiate between HIV versus AIDS. So HIV being a virus that causes the infection, but AIDS is this acquired immunodeficiency syndrome, which is like the last stage of like the AIDS disease. So if you think of it like kidney disease, you know how they have like, oh, you're like CKD1 versus like CKD5, where 5 is the worst. Like AIDS is kind of like where you've progressed all the way to the end standpoint. And so kind of in the name of the AIDS thing is kind of what happens during HIV infection. Essentially, the virus attacks your body's CD4 cells, which is your body's immune system, and then you're not able to fight off infections as well. You get put at risk for a lot of additional sort of opportunistic infections, as we would call them. And essentially, it kind of just repeats itself until your body has no CD4 cells or very few CD4 cells. So we're going to walk through this life cycle together. It'll be a very abbreviated, abridged version because as much as I like the topic, it's always never fun to talk about pathophys. But I guess the first few steps in the HIV life cycle is the attachment and binding and fusion part. And so essentially attachment is what it is. It's when the HIV virus binds to your body's CD4 cell. And so for your body to get infected with HIV, it has to get attached to that receptor on specifically CD4 cells. From there, what happens is HIV will enter through the fusion phase. So you can see the HIV virus releasing its contents into the CD4 cell walls. The next part is one that I think is one of the most important steps. All of them are important, but this is a real big hallmark because this is where a lot of our medications work, and it's called the reverse transcription phase. And so HIV is a virus, and viruses have RNAs. Luckily, we're humans, and we have DNA, which is cool, but HIV is smart, and it figures out how to turn its RNA into DNA. And so the process in which HIV converts its RNA into HIV DNA is through reverse transcriptase. And so this reverse transcriptase enzyme works in making it so that our body gets fooled by HIV and thinks that it's something that we want to incorporate into our system. And so a lot of the medications we'll look at work at this phase. So remembering reverse transcriptase converting HIV RNA to HIV DNA. Next up, we have the integration. And so essentially with this one, HIV DNA works with our CD4 cells. Our body gets tricked. It thinks that it's, part of our body and integrates itself into it. There's a few medications now that work at this integration phase. And so just remembering that, as you can see here, our body gets confused. Its CD4 cell DNA also gets incorporated with HIV DNA, which is not great. And then from here, we have transcription and replication. During this phase, essentially, new HIV particles are made. They package new little viruses so that they can go and infect other CD4 cells. Nothing too huge on this one. And then we have this assembly and budding phase, so I kind of alluded to beforehand. Big takeaways from this one, it's just essentially the virus infected one CD4 cell. It's gonna use that CD4 cell, kind of take its DNA, make a new virus particle, and go find another CD4 cell in your body. And so it's really good at doing that and really efficient at doing that, which is why HIV is a progressive disease if you're not treating it appropriately. So it's really good at attacking CD4 cells and really good at making your immune system not work as well as it should. So I guess I should have prefaced, I do have these checkpoints kind of built in because, I don't know, just to keep you guys, hopefully making sure I hit the high points, but in which step of HIV life cycle does HIV convert its HIV RNA or genetic material into DNA? You can just shout out. What? Yep. So it is the reverse transcriptase phase. I think I kind of harped on that because this is where a good chunk of the medications work. Okay, so now that we know how HIV works inside of our own bodies, a lot of the fear and the stigma, I think, associated with HIV as a whole is, how is it spread? And so I like this, infographic from the HIV, the National Institute of Health. I think it's really interesting that they have to be so explicit in being if someone has HIV, it's okay to share a desk, a hug, etc. with them. But I think that just goes to show that there's a lot of still misinformation and still a lot of stigma surrounding the disease as a whole. And so again, us being in pharmacy and seeing so many patients, great opportunity to educate, patients, not just the patients who are picking up their HIV medications, but other patients, as well about the disease state as a whole. HIV spread, I'm sure we all know, through bodily fluids as listed out there. I do want to highlight this undetectable is equal to untransmissible. So we talked about how HIV replicates inside of your body and things like that. But with the medications that we have now, what's really cool is we can virally suppress you or get it so that there's so little virus inside your body. Unfortunately, at this time, we don't have a true cure for HIV, but we are able to help you become undetectable. And when you're undetectable, that means you're untransmissible. So if you want to go and have a baby with a partner who's HIV positive and they're untransmissible, theoretically, as long as they're taking their medications as prescribed, that's not a concern. You don't have to worry about transmitting the HIV from your partner to yourself and hopefully not to your baby as well. So this is something really, I think, big and important to harp on because it is really scary that, you get told that you have this disease that's essentially no cure for, but there is a lot of hope in the sense that we're able to get you to a point where you don't have to worry about transmitting it to your partners or to anyone else. Just want to make sure. So we're going to hop into, I guess, the bulk of this presentation, which is the antiretroviral therapy treatments. With that, before I start talking about it, I guess I do want to mention, what are the goals? Why do we treat people for HIV, right? What is the purpose if there's no cure? Kind of how do we wrap our mentality around that? Well, there were trials back in 2015 that were called the Temprano and START trials. And basically they showed that once someone is diagnosed with HIV, we should immediately be getting them on some sort of antiretroviral therapy. And why? Why do we want to do that? We want to do that to hopefully reduce the associated morbidity. If we think back to the 1980s, even the early 90s, not a great time in terms of survival, in terms of longevity of life once you were diagnosed. I know that I wasn't around for that, but reading the literature and things about it, it was not a great time. And so now that we have this effective therapy, like how can we make these lives better? How can we make them longer? How can we have them get back to sort of a more quote unquote normal? So all of these are sort of the big goals, but I think the big one is that associated morbidity, right? Like we have drugs that work that can help you live better, longer lives and making you live essentially like a quote unquote back to normal life once you have this disease. And so I harken back to, HIV then versus now. 1987, I was not born yet, but that is when the first medication was approved by the FDA to treat HIV as a disease. So if we think about, when this whole HIV, I guess, pandemic or endemic ensued and looking at how quickly we have progressed from 1987 to where we are now, it's pretty impressive. So remembering 1987, AZT being your first drug, 1996, we have a triple drug therapy, also known as like HAART or highly active antiretroviral therapy, which is what a lot of our patients that have HIV are on right now. And then what I thought was really cool that I wasn't super aware of was the CDC in, I want to say 2019, so the mid of 2019 released this 2030 plan for 90-90-90. Unfortunately, because of COVID in 2020, we don't have great data on where we're at with this right now. But what's really cool is that this 90-90-90 plan, 90-90-90 plan, is really wanting us to reduce new HIV infections by 90%. So how are we doing that? We're doing that through one, making sure patients are adherent to their medications, making sure they have access to their medications, making sure they have appropriate follow-up. But then we're also looking at PrEP, so pre-exposure prophylaxis, which we're going to talk about a little bit later. So unfortunately, I don't have a really great, stats to give you in terms of where we are in the CDC 2030 plan, but like anything, hopefully in the next 10 years, we can reach these goals or at least push ourselves to get closer to reaching these goals. And I will say that they did want to focus on like 4 key strategies with it, and that's through diagnosing all people. So I harken back to that first slide where I showed that, only 6 out of 7 people knew. So diagnostics and making sure people know they have the disease is important, but then also treating them, right? We talked about the importance of like rapid starting for treatment. They also want to talk about prevention, so we'll talk a little bit later about pre-exposure prophylaxis. And then the last thing is responding. So like anytime we see a HIV outbreak in the community, we want to respond to it as quickly as possible. This past year, TCU, so Texas Christian University down in Texas had, I think they were in Dallas, Texas, sort of had a little mini outbreak, and they seemed to respond to it pretty quickly and got that under control. So again, just kind of looking at all of that in terms of the 90-90 plan. Okay, so we talked again about like when to initiate therapy based on those trials, but then more importantly, what type of medications do we want to use? Talked about how we started with AZT in like 1987, then 1996 we got to this 3-drug regimen. And basically now where we're at in terms of treatment is at this 3-drug regimen. So all patients who haven't been on any sort of therapy before should be started on a 3-drug treatment regimen. Think about it this way, I guess you're told, oh, I have this new disease state, I now have to take 3 medications. That's a lot to handle. Luckily, a lot of these treatment strategies are either single tablet regimens or 1 or 2 pills. So we're going to talk a little bit more about like medication adherence and pill burden, which I'm sure all of you are way more familiar about with just seeing the number of patients you do than I am. And if you have some insights on that, I'd love to hear, but we're going to kind of go through all of that as well. So a nice little checkpoint to make sure you're not asleep. What was the first FDA-approved medication for the treatment of HIV? AZT, yes, in 1987, a few years before I was born. So the first class of medications we're going to talk about is the nucleoside reverse transcriptase inhibitor. So if you remember when we talked about that life cycle, we talked about how HIV RNA turns into HIV DNA. These medications that I have listed on the screen work at that point in the DNA replication process. These medications, for the most part right now, are very useful when they're used in combination. So as you can see up here, I have their like first-line therapy. And so typically a lot of patients will be on tenofovir alafenamide, tenofovir disproxil, TAF, TDF, or they'll be on emtricitabine. So these medications you might not necessarily see by themselves, but you will see like in combination with other medications when patients are coming to pick up their medications. Abacavir, I don't know if any of you are super familiar with it. I personally haven't seen like a lot of people on it just because you do have to have this like gene testing, and if patients have Hep B as well, you can't use it because it's like a contraindication for treating the Hep B as well. So on the screen for completeness, but I'm probably won't be seeing much of it in your practice. The next type of medication class is the non-nucleoside reverse transcriptase inhibitors. Basically, their structure is a little different, but they work in that same spot. They work in that HIV reverse transcriptase phase where it's that HIV RNA to DNA step. The big one in here is AAPT. So AAPT, fun fact, I guess, used to be the first line therapy for like all new start patients. So a ton of people used to be on AAPT, but then they found out there's a ton of like CNS, I guess side effects with it. So no longer used, a lot of psych issues. Some people reported like increased like feelings of suicide and things like that. So AAPT for the most part not used now, but used to be used relatively frequently. What made it so, I guess, hallmark was the fact that it was the first one pill, once a day regimen. And so for a lot of providers, it was like, oh, let's get these to patients because it's easy. They can take it once a day. They, don't have to take multiple pills. They can just take it and go. But then they found that there were some additional issues with that. So just being aware that, you still may have some patients on AAPT, but a lot of new start patients probably won't end up being on that one. Not to say that that medication is wrong, it's worked for a lot of people, but just so you're aware, with people. The next medication class that I want to talk about is the integrase inhibitors. So if you remember back to that previous slide where we talked about the integration phase, this is where that medication works. These are sort of like our hallmark drugs right now. So these integrase inhibitors all end in cabotegravir. When I was studying for exams, I was like, I've got to figure out how I can memorize all of these so that I can get a good grade on this exam and like pass my classes. So just, if you see anything that ends in tegravir, you can assume it's an integrase strand inhibitor. I guess just by a show of hands, like how many of you have like either dispensed Biktarvy or like seen Biktarvy? Yeah, that's right. That's like, I feel like the go-to now, like all providers are like on board with it. What's really cool about Biktarvy is that cabotegravir has not, I guess up to my knowledge from I think 2018 or 2019, hasn't shown any resistance to that specific integrase strand inhibitor, which is pretty cool in terms of like making sure that the medication is still effective. Dolutegravir, rilpivirine, you'll see different formulations of those as well. I kind of haven't spent too much time on like the formulation, I guess, column because most of the time patients are on the tablet formulations. I guess, show of hands, do you mostly see like the tablet formulations? Okay, that's kind of what my experience has been as well. I think it's cool that it has like suspension and chewable tablet options, but I haven't really seen them too much in actual practice. Other important, like I guess, points to remember, this no cation, so like aluminum, magnesium, if patients are coming in and you notice that they're picking up their Biktarvy, but they also have like a magnesium supplement or something like that, maybe just making a note to your pharmacist or just, being aware that like, hey, we should probably counsel this patient, or hey, we should probably have the pharmacist counsel this patient on not taking these two medications together because it can decrease the effectiveness of the actual integrase strand inhibitor. So a lot of these patients are very aware, of like the medications they're on and things like that, but if you have a new start patient, I think that's always just important to be aware of as well. Okay, the next one is protease inhibitors. These medications I'm not like the biggest fan of. They're no longer first-line treatment, and a lot of that has to do with the fact that they have so many drug-drug interactions. So like, unfortunately, my experience has been that like HIV positive patients or patients on PrEP also have comorbid conditions. Unfortunately, like not everyone is in perfect health, like, and like running 10 miles a day and like, eating super healthy type of deal. So they're on other medications. And with these protease inhibitors, unfortunately, a lot of them have drug interactions that make them less effective. The other thing to note is that certain solutions, if that is an option, have really high alcohol content. So, you know, might not be the best option for a patient who's on Flagyl, right? Like looking at that interaction there, and maybe might not be the best medication choice if a patient has like a substance abuse disorder or anything like that. Things to just kind of have in your back pocket. For the most part, I typically don't see a ton of these just because of all those interactions. But if you do see them, just note that, you know, interactions should be something to be aware of for yourself, for the pharmacist, for the patient as a whole. Oh, and then the other big thing is that, yeah, they do cause like metabolic disturbances as well. So in terms of just like increased like body fat, like increased resistance to insulin, all of those things that are not great in general, and especially if a patient's on other medications as well. The next one I want to briefly mention is pharmacokinetic enhancers. So essentially these are just like boosting agents. They have no actual efficacy against like the HIV virus as a whole, but they are really nice because they help like the other drugs work better in the body. As you can see, cabenuva used in like so many different combination formulations that are listed up there. I don't really have anything too much more to like add. Oh, I guess like if for some reason a provider called and was like, oh, can we switch between like cabenuva versus ritonavir? The answer would be no, just because even though they are both pharmacokinetic boosters, they're unfortunately not interchangeable with one another. Questions? I feel like I've been like just rambling on for you guys.
I have a
Oh,
question.
yeah.
Sorry. So the boosters, I've never heard of enhancers or boosters, as you put it. So they have no therapeutic value on their own. The therapeutic value is only when they're used in combination.
Yes, so they're going to be used, thank you for the clarifying point, they will be used like in combination. These medications have to be given with these other medications, and essentially they're just helping the other medications work better. Thank you. Please stop me at any time as well, like so I'm not boring you. But the next one we want to talk about are fusion inhibitors. The only one in this class is Fusion. It's an injection. I haven't really seen this one used. It's nice because you can have self-injections for it. I guess, show of hands, like, have you seen this one? I don't know if any of you, not too much. That's kind of what my takeaway from this one's been. It's like, it's really cool that it's an injectable, but when you can take a pill instead of injecting yourself, I feel like most people are going to take a pill instead of the injection. Okay, we're getting into the more, I guess, like niche or newer type of HIV agents. This one is a CD4 post-attachment inhibitor. Long story short, it works like after HIV has attached to the CD4 cells. It's what's nice about it, or Trogarzo, what's nice is the fact that it's an injection that's given once every 2 weeks instead of daily. So if I haven't, I guess, been super explicit or super clear, all the other treatment strategies that patients are on are a daily tablet. So you have to take a medication every single day to be adherent to help virally suppress yourself. So once we're getting into these newer agents that are having sort of, I guess, longer action and having fewer administration times, we're looking to sort of help those patients overcome sort of that adherence burden or that pill burden that we talked about earlier. This one will have to be administered in a healthcare setting just because of the possible infusion reactions. This one is one of my favorite medications on a personal level because we did a lot of research with Maraviroc or Cell Sentry. I thought it's really funny because it's a CCR5 antagonist, and the brand name Cell Sentry tells you what it does. It prevents the HIV from entering the cells, so Cell Sentry. The marketing team, I'm sure, got paid a ton of money to come up with that one. But I think that this one was a really great option to have more specific or more narrow therapy. What's hard with it, though, is that you have to have a CCR5 test done on you, because if you don't have that CCR5 co-receptor, the drug doesn't work because there's nothing for it to attach to. But interesting. Don't know how much it's actually being utilized just because that's one additional step providers have to do and one extra step providers have to take to be able to get patients on this medication, which is difficult, right, when we talked about how we really want patients to start therapy as soon as possible. So this one, Rukobia, is relatively new. It came out, I want to say in 2019, 2020. Rukobia is the first medication approved in this class. So it's a GP120 attachment inhibitor, whatever, that doesn't really matter. What's cool about it is that it's being used for patients who have recently failed or are having resistance to the current HIV medications that they're on. So the trial that was done to get this FDA approved looked at patients who were on therapy for a really long time, but their viral load was still like not lower and not going down. So they switched patients to this Rukobia. And so a lot of these patients who've, been living with HIV since, the 90s or early 2000s, sometimes can develop resistance to the medications because unfortunately HIV is smart and it finds ways to work and mutate in your body, just kind of like we've seen with COVID and that virus as a whole as well. And so Rukobia is really nice because it's a potential treatment option for those patients who have failed other current treatment options. Okay, so if I guess a highlight slide to take away, most patients I feel like that you'll see and that you'll dispense medications to will be on these single tablet regimens, one pill once a day because it's easy. So if you take nothing away from it, I feel like the big ones that I've seen, we talked about AAPT, the CNS issues, just being aware of that. Biktarvy, I feel like, I don't know, providers must be getting some sort of kickback because they prescribe a lot of Biktarvy. So I'm sure a lot of you will see Biktarvy when you're working. We're gonna hit on Dovato and Triumec a little bit later. Those are pretty much all of the ones that I see a lot. Are there other ones that I guess you guys have dispensed quite a bit of that aren't up there in terms of the one treatment regimens? As a whole, no. But yeah, Biktarvy, right? I feel like every provider's that's their go-to medication right now. Okay. Again, just more fixed dose combinations. These are the reverse transcriptase based ones. We're going to talk about Descovy and Truvada a little bit later as well. So keeping those two in the back burner. More just NNRTI based ones, just for completeness, so you guys have an idea of the classes that they fall into. Not super important, but just for completeness sake. Same thing with the integrase strand inhibitors. Protease inhibitors, we again talked about how they're not super big right now, but just being aware that they, they are still maybe on the market. Okay, I am really excited to talk to you guys about this. So it's a new novel agent. It's called Cabenuva. I guess show of hands, have any of you heard of Cabenuva yet? Okay, so it got FDA approved in January of this year, and Cabenuva is cabotegravir. So based on that name, what class does it fall into? The integrase strand inhibitors, because that's tegravir. So it's a combination product, and it's the first long-acting injectable. So it's a once-a-month injection that you'll get in a healthcare setting. So clinic, most likely not hospital, because normally they don't pay for inpatient stuff like that. But what's really nice about it is that patients only have to get injected once a month. The, I guess, caveat to that is right now it's currently only FDA approved for patients who are already virally suppressed. So that means that patients have to be adherent to the medication regimen that they were already on before they can get onto this medication. And in addition to that, there's sort of a lead-in oral therapy. So unfortunately, we see a lot of patients who maybe would benefit from this because they're not adherent to their current regimen, or maybe they aren't virally suppressed. But unfortunately, the patients that are able to use this are only the ones that are currently virally suppressed. What's really neat and really cool is that there's currently studies being done for patients who are treatment naive, so haven't been put on HIV medication regimens before. And then also it's being studied as a 2-month long-acting injectable instead of 1 month. So instead of coming in once a month, patients would come in once every 2 months. And so UNMC, I guess, does research with that. And I know they were part of the original trial, so I'm assuming they'll also be following up with the other trials as well. So that's something to look forward to on the market. But I did want to make you guys aware of this. And it's really cool because it's one of the first long-acting injectables. And this is what I spent a lot of research time on in pharmacy school. And so to see something like this come to market is really neat. The other big thing, so the Department of Health and Human Services, when the FDA approved it, came out with these recommendations. Again, like I said, unfortunately, patients have to be currently virally suppressed. So if you have a new HIV positive patient come in, they can't just jump on this long-acting injectable. But if they've been virally suppressed for 3 months, this could be an option for them, which is really neat. There's other, fill-in type of, I guess, objectives that they need to hit, but really cool, brand new, came out in January. The dosing on it, big takeaways, like I said, there's a lead-in therapy, it's monthly. What is nice though is that they did make recommendations for like what happens if, a patient's not able to get to their monthly injection. And so if the patient knows they're gonna be out of town and away from their clinic, they can sort of bridge with the oral tablet formulation before they need to go in to get their dose just at a later time. Questions about Cabenuva? I think it's really neat, and I'm hoping that it'll get approved for HIV treatment naive patients, so that we can see it used a lot more. Especially, I think since there is that stigma sort of still around picking up your HIV medication and things like that. So being able to go into a clinic visit or a nurse's visit and just getting a shot and then being able to leave, I think will really help us reach that CDC 90-90-90 goal that they're looking forward to. So, true or false, Cabenuva can be used as initial therapy in HIV positive patients who do not have documented viral suppression. False, yes. So big thing, right? We went over that quite a bit, harped on that one, which hopefully we'll see in the next coming years that we're able to use it in that population, but unfortunately not now. Okay, so, oh yes.
Is the reason it has to be injected in clinic because of the type of injection, or are we checking for like side effects, things like that? What's stopping it from being an at-home injection?
And now, that's a great question. So the volume of medication that needs to go into your body is quite large in comparison to like what people would normally self-inject with like either insulin or I guess like GLP-1, like Victoza and things like that. So they only studied it as a in-clinic visit. I would love to maybe see like that being something moving forward, but I think that even at that point, like it's still better to be able to go in once a month to get an injection than have to remember to take a pill every day. But hopefully, right, like that they'll be able to do it. And then to follow up on that, not really a ton of huge side effects because they haven't seen patients on this for a super long time since it's relatively new. And I think because of that, this is me speculating, I think because of that they do want to monitor a little more closely. But hopefully in the future we'll get to see it as an at-home. Great question. Any others? I think Cabenuva is really cool. Okay. So these are just sort of guideline practice recommendations that I wanted to go through. There's a lot of words on the next upcoming slides. I hopefully will highlight the big takeaway points for you so that you can be aware of them. But just know that there's very detailed guidelines out there if you want to read up more on it for yourself. So most recently, the Department of Health and Human Services in 2019 released the guidelines. Basically, it says that every patient who is on antiretroviral therapy should be on some sort of combination therapy. We are no longer treating people with single-dose regimens, and so those combination therapies for new start medication patients should have at least 2 nucleoside reverse transcriptase inhibitors and then 1 other drug. So patients will always be on at least 3 different drugs that hopefully come in 1 tablet. But just remembering 2 NNRTIs, which is why I spent so much time on that, like NNRTI life cycles. Other questions about these guidelines as a whole? Additionally, I just wanted to follow up with these are the specific agents that they recommend. I think because DHHS specifically recommends that cabotegravir, tenofovir, emtricitabine combination, also known as Biktarvy, is why we see so many patients on it. So hopefully no new resistance gets developed and we're able to use Biktarvy in a lot of these patients. More guidelines, just to note that like the World Health Organization in 2019 also released a set of guidelines, but they're very much in line with what the Department of Health and Human Services has out as well. So which is nice when guidelines all match up and we don't have conflicting info coming from multiple sources. Here's just some options for second-line therapy. Basically, with the second-line therapy, we're going to see patients transition to these medications once they've failed the first-line therapy. So what does that mean by failing? You know, they're not able to be virally suppressed. Maybe they weren't adherent to their regimen for some sort of reason and developed like resistance that way. Lots of different reasons, but just knowing that, you know, if you do see a patient who was on Biktarvy at one point and then a couple months later or a couple years later is switching to a different medication, that could potentially be the reason why. And it's not like the provider, you know, misprescribed or something like that, which we know happens sometimes. So again, to reiterate, just here are all of our 1 pill once daily regimens, taking home points. Again, those 3 on the top are, again, like the big ones that we see as, because they're 1 pill once a day. And then just remembering that all of them should have theoretically 2 nucleoside reverse transcriptase inhibitors. So, according to the 2019 guidelines, how many reverse transcriptase inhibitors should be in combination with a third agent? 2, yeah, 2. So I guess the basic takeaway is I don't think you need to necessarily remember that there's 2 NRTIs, but just remembering that most patients should be on a combo pill of some sort. Okay, and then I wanted to take a little bit of time to hit on storage and stability requirements. And so what's important about these is that when you're dispensing these medications, you have to, I guess have is a very strong word, you really should be trying to dispense them in their original container because they have special desiccants. And I bring this home because a lot of you that are very familiar with HIV medications may know this really well, but for people who maybe aren't as aware of it, if a prescriber writes for 28 days, but you know it comes in a 30-day pill bottle, that might be something where either you want to reach out to the provider or have the pharmacist reach out to the provider, because we really shouldn't be breaking these bottles open, because the concern is that the drug isn't going to be as stable. And just like I said before, there's so many like different medications in that one pill that it's really important that we keep it, you know, as pure and is in the intact form as we have it. The other thing is that I talked about all those different formulations, and we talked about how we mostly see tablets, but unfortunately, unlike, you know, other medications that you can switch from the tablet to the solution formulation or, you know, vice versa, HIV medications don't work like that, and so they're technically not interchangeable. So really having a conversation with your pharmacist or really having a conversation with the provider about, like, you know, hey, I saw that you wrote for a solution instead of a tablet this time, but the patient has always been on a tablet, like, are you aware, like, you know, is this really how you want to proceed forward? And just making sure that they're aware of that. Different requirements for storage in terms of room temperature versus fridge and things. Ultimately, like, you guys all are very capable checking package inserts, just double checking if you're not sure. And a lot of pharmacists, like definitely myself included, like I don't know all of them off the top of my head. So for some reason, it seems like your pharmacist might not be aware of like the storage thing, just reminding them, like, we make mistakes, like, hey, you know, that needs to go into the fridge, or like, hey, that shouldn't be opened until, you know, we're dispensing it to the provider. And I'm sure, I guess I can speak for myself, like I know that I would really appreciate that so that I'm not wasting a very expensive medication. Okay. A little bit more specific ones. The one I did want to talk about is if you ever do see that Fusion injection, once you like reconstitute it, it has to be used within 24 hours, so within a day. So just making sure, like, you know, you're not reconstituting it until patient gets to the clinic or patient gets to provider's office. Otherwise, it's a very like expensive waste of a medication that I'm sure your pharmacy director, whoever, would not be super stoked about that you had to toss. Again, the Cabenuva injections, those also have very specific guidelines on how they're used, but hopefully once you start seeing them more frequently, that'll be something you're just more familiar with. But the Fusion ones, I know we said we haven't seen a ton of it, but just remembering 24 hours there. So once reconstituted, how long do you have to use the medication? 24 hours, yes. So hopefully, you know, if you take nothing away from that, just remembering that point too. Okay, I do want to take a little bit of time to talk about PrEP versus PEP. So pre-exposure prophylaxis versus post-exposure prophylaxis. So I think you raised your hand and said you're from Colorado, and so pharmacists there can like prescribe PrEP if I'm not, right? So I think this is really cool. And so for people who maybe aren't aware of what PrEP is, or maybe aren't 100% like up to date with it, which is totally cool. It's essentially a medication that you can take every day when you're HIV negative to prevent you from getting HIV. So like I talked about earlier, you know, you have an HIV positive partner and you don't have HIV. How can I, you know, put myself in a position where I can, you know, maybe prevent myself from getting HIV? And PrEP is a great way. So I don't know how many of you watch TV. I probably watch too much, but now you've seen those, I don't know if you've seen those commercials where there's people like, I'm on the pill, and it's like, I'm on like Truvada or like Descovy. And so those are the PrEP medications. What's really cool is the efficacy of it. So approximately 99% efficacious at reducing your risk of getting HIV from like sexual intercourse, and then 74% of reducing HIV from IV drug use. So those numbers are really great when you think about like, if you are gonna be in a like high risk situation, like how can you prevent yourself and decrease that risk? PrEP is a really great way. But then we think about like our healthcare workers, right? Like you're taking care of an HIV positive patient and then you accidentally get a needle stick. What do you do then? Post-exposure prophylaxis, so after you've been exposed. Ideally, you would take it within 72 hours, so it's kind of like emergency contraceptives in that sense, so it's that 72-hour time window. With this one though, instead of taking it every day for the rest of your life, you just take it every day for 28 days, so essentially like a month long of therapy after you've been exposed. And again, it's also for people who don't have HIV but have been exposed. So like maybe you're a nurse or you know a nurse that got, you know, pricked with a needle from an HIV positive patient. Post-exposure prophylaxis is probably the route they're gonna go. Just like with, you know, emergency oral contraceptives, not 100% efficacious, but the sooner you take it, the more efficacious it is. Questions on PrEP versus PEP?
I have a quick question. Why do you think the efficacy is different versus the HIV from sex and IV drug use?
Yeah, that's a great question. So looking into like the studies behind of it, a lot of it has to do with the type of body fluid that's being exchanged during those two different scenarios. So with sex, it's most likely the bodily fluid's gonna be semen or things like that, which carries slightly lower risk of transmitting the HIV versus blood contact, which is what we get when we have IV drug use. Great question.
Makes
Thank
sense,
you.
yeah.
Yeah, thank you. Good question. I talked about these two medications earlier, is Descovy and Truvada. I'm sure you'll see multiple commercials for them. The key takeaway is that both of these can be used for PrEP, but Truvada can be used for PEP in addition to PrEP. And then Truvada can be used in essentially all patients, so men, female, all of those. With Descovy, it's not approved for anyone who has vaginal receptive like therapy, so essentially females in that case, or if there's a trans person or anything like that. So just kind of being aware of that, maybe like you have a patient and the provider prescribed Descovy for PrEP, but they're female and having vaginal like sex, it wouldn't be appropriate for them. Just making that aware. And you know, pharmacists might not know this as well, so that's just a really great take-home point for them to double check on, because it's not like we get a flag, you know, or an alert in our system or anything like that. It'd be cool if we did though. But as you can see, they're essentially like the same drug, just the different salt formulation of the tenofovir. TDF, if you're curious, just slightly less side effects compared to TAF. So, you know, how drug companies make their money. Okay, so I think this is coming up on our last few questions. But a nurse was taking a blood sample from an HIV positive patient. The nurse is stuck with a needle. She or he is negative and is not an IV drug user. Should she get PrEP or PEP? PEP, yes, post-exposure prophylaxis. And then, same nurse from that question, you know, speaks to the primary care provider. They need PEP. What's the maximum amount of time from when they were stuck with that needle to be receiving it? 72 hours. Yep, it's kind of nice, right? Just like emergency, like birth control or contraceptives to remember. Okay, the last thing I want to hit on with you guys is just costs and accessibility and adherence. I think this is where we as pharmacy can play a really large role in helping with access. So cost $2,000 to $4,000 a month for 30 pills. That's absurd. Like, who can afford that on their own, right? Cabenuva, I think they came out and said it's $6,000 a month. Like, insane, right? Like, how do you afford that? That's a mortgage, rent, whatever, times so many times over. So I did want to bring your attention to patient assistance programs, which I'm sure you're all familiar with. You know, it's very similar to like ones for like Advair or for other like specialty type of medications. I'm sure you're also very aware as well. I did also want to point you out to the Brian White Age Drug Assistance Program. I guess quick show of hands, have any of you heard of? Okay, yes. So basically the federal government gives money to the states to be allocated, to be used. There is a application process, you know, there's forms you need to fill out and things like that. But it also helps patients like get access to a lot of these medications that they might not have access to beforehand. And then with that, within Nebraska, the Nebraska AIDS Project is a really great resource. They connect a lot of patients to different resources as well. So if you're from here, look into that. If you're from out of state, I don't have, I'm not super aware of those, but I'm sure there's also programs that are very much able to help as well. Brief talk about adherence. To prevent the resistance from developing and preventing patients from quote unquote failing therapy, greater than 95% adherence. So what does that mean on a day-to-day basis? That means within a month, theoretically, you can only miss one pill, which is insane. Like that's tough, right? Like I think about taking a multivitamin every day and I'm like, I definitely forgot today. So like I'm kind of like out of luck for this month. So just really, you know, helping patients find the resource or really like encouraging or reassuring and helping them, you know, see that like, yes, it's really tough and I understand, but you know, it's really important to have that adherence. And so maybe you guys can have a role in like following up with patients who you know are picking up their medications late or things like that. And I think that's a really great way to make a really big difference in HIV as a whole. So in summary, HIV, if we remember back, it's that virus that causes AIDS. It's different than AIDS. Unfortunately, antiretroviral therapy isn't a cure for HIV, but we are on the way to being able to virally suppress people and get them to that undetectable is equal untransmittable level. Lots of different formulations, but like we talked about, you're mostly going to see the tablet formulations, multiple different storage and stability requirements, Fusion, Cabenuva, all of those are going to have different ones. Always looking at the package insert if you have questions, because I definitely won't remember, and I'm sure your pharmacists will all really appreciate when you're like, oh, hey, I checked in the package insert for you already. And then I really do want to talk a lot about just prep for HIV-negative patients, and I think that, you know, we talk about pharmacy being such accessible healthcare workers, right? Like, you guys see patients so often, whether you're in a hospital setting or in a community retail long-term care setting, and I think you have a really great opportunity to help maybe like identify and recognize patients that might have high risk or be in situations that put them at high risk, and really just helping educate the general population about